All right, why don't we go ahead and start while the crowd is filtering back in. We are going to switch gears now and talk about PNH as part of the PNH panel. If Amy had a tough act following David, I have another tough act following her, so we will try our best. If I could have the first slide up, please. Oops, backwards. So I've invited several speakers here who are preeminent in the field, including Daria Babishak from the University of Pennsylvania, Jarek Masajewski from Cleveland Clinic, Taussig, myself from Duke, and Antonio Risitano, who will be joining us virtually from Italy, which we will all start from. I'm going to let Daria start out. The first two talks are going to be a little bit more on the pathophysiology of the disease, and then myself and Antonio will talk more about therapies that have evolved. So, Daria? We can switch the slides.
Hello, everyone, and it's a true pleasure to be here with you today to celebrate the 40th anniversary for AAMDS. Whoops, blank. So today, I will switch gears now and talk about the basic pathogenesis of PNH, and I know we will talk a lot about the great advances in complement therapeutics in the second two of the PNH talks. So of course, this is a bit of a review. We all know that PNH starts out by a series of events that are started with a somatic mutation in the PIGA gene. That gene is important for glycophosphatidylinosyl or GPI biogenesis. And then with these mutations, we have now an absence of all of the GPI-anchored proteins. But aside from that, another critical step that is required for this to cause disease is the clonal expansion of GPI-deficient cells. Now, of course, through work of many in the field, we know that many individuals, healthy individuals, have small populations of PIGA-mutated cells, so of these GPI-deficient cells. And in all of us, these may circulate, but they do not expand, and they do not cause clinical disease. However, larger expansions that are rare are quite pathologic, and these generally occur in two clinical contexts. So these occur, let me see if I can figure out how to use a pointer. Do we have a pointer? Here we go. No? Okay, well, so these occur, and you can see with the larger clone sizes, these would cause clinical PNH disease with hemolysis. And then we have another end of the spectrum where patients who present primarily with bone marrow failure symptoms have small clonal populations of these cells. Now, the peculiar association between PNH and bone marrow failure has now been observed over half a decade, over half a century ago, as mentioned here in the famous editorial, where indeed we now know that aplastic anemia is the #1 risk factor for development of PNH. And then conversely, in patients with aplastic anemia, the most common somatic alteration are the PIGA mutations. Now, the question or the connection between these two entities has been thought about for decades, and many in the field have puzzled over this. And as we can see here, this is from the very prescient book chapter that was authored by Rottoli and Luzzatto, who have discussed this now over, so this was published in 1989, so over 30 years ago, where they envisioned that we can have a somatic mutation in PNH, and then once this mutant clone expands and comprises a large proportion of an individual's blood cells, the patients then would be identified as having PNH, of course, by the HAMS test and also by clinical symptoms. Now, in the case of aplastic anemia, two additional factors were postulated. So first, as we can see by the decrease in the stem cell pool, as you can see in those solid lines, we see in general we have a decrease of the total stem cell pool, as well as an advantage that is experienced by the PNH cells when they're spared by the immune attack. And you can see this from their publication where they envisioned that there is a force here shown by those black marks that is destroying the normal or the red blood cells with the pink cells or PNH cells that are expanding. Now, what is the etiology of that immune pressure? And so what is the specific selective pressure that's causing PNH cells to explain? And there have been multiple theories. And in the next few moments, I will give you some of the just snapshots from some of the pivotal publications on this topic, but you can see some theories including evasion of NK-mediated attack, of CD4-mediated attack, NK T-cell-mediated attack, etc. So as one of these that I would like to highlight was one of the earlier studies. Now this was published by a team from Japan led by Nagakura, where they have established in multiple models of PNH using leukemic cell lines, and then they exposed these to NK cells. And you can see that in general, various PNH phenotype cell lines were resistant to killing by natural killer cells. And they have proposed that the mechanism for this is that the PNH cells that are deficient in all GPI-anchored proteins are now able to survive because they're missing GPI-anchored ligands for these NKG2D receptors. So this is a critical receptor that is present on NK cells, also present on some forms of T cells. And that in general, as you can see here at the top, we have the GPI positive cell that is expressing these stress-induced ligands. Some of them are transmembrane, some of them are GPI anchored, while the PNH cell is missing them. Another alternative or additional mechanism was proposed by Murakami. So this was a study using a PNH mouse model where they evaluated the ability of CD4 cells to be stimulated by PNH compared to wild-type cells. And as you can see here, when PNH cells were incubated in the presence of peptide, you could see that CD4 cells were stimulated to a significantly lower degree. And then they also developed the first model in which they could see this advantage in an in vivo model, where they essentially took CD4 cells, infused them into the mouse at the same time as they infused fetal liver that was chimeric for PNH. And you can see there with the red arrow that shows the y-axis there is the percent, and we can see the expansion or the predominant majority of the cells for the PNH phenotype. And they concluded that essentially these PNH cells were able to evade the immune attack by the CD4 cells on the progenitor population. And of course, as the progenitor then weaned, the lines also come down. So for this, the model then that they proposed to explain their observations was that in PNH cells, we are missing a GPI-anchored co-stimulatory molecule that could be important for activating or stimulating the CD4 cells. And one such molecule, for instance, in mice would be CD48 that is known to contribute to CD4 cell activation. There is one additional theory that I would like to highlight. And so this was conceptually quite different. This was now published over 10 years ago by Gargiulo and colleagues from Italy, where they noted that patients with PNH, as well as aplastic anemia patients, have small but expanded populations of specialized NK T cells. So these are T cells that have an invariant T cell receptor that now recognizes lipid antigens. And so the hypothesis here was that these patients have expanded populations of NKT cells that can attack cells that present the GPI itself, now in the context of the CD1D molecule. And so then PNH cells would arise. And so this would be the model that would explain this type of immune attack. Now, all of these are quite different, and so where does this leave us? The most important thing I think that the data show is that PNH cells have in general altered interactions and can have reduced susceptibility to multiple immune cell types. And of course, it's not surprising, right? So in addition to the loss of PGA, these cells lose a lot of GPI-anchored proteins. So in one fell swoop, they're losing over 150 GPI-anchored proteins that are known, of which close to 80 are expressed in a variety of hematopoietic cells. And these have a variety of functions, so they participate in cell-to-cell interactions, adhesion, co-stimulation, you name it. And then, of course, there are probably the secondary effects. So the membrane may be altered. Additionally, we may have altered lipid metabolism, et cetera. So where do we go from here? I think what the biggest challenge for us now is to determine of many potential mechanisms, which ones are the most relevant in vivo. And here we can think about, for instance, about this unique association of PNH and aplastic anemia. We now know that one of the main effector cells in aplastic anemia are the cytotoxic T lymphocytes. So these, for example, recognize hematopoietic stem cells by binding through the MHC class I. And so this particular mechanism hasn't yet been fully explored, but certainly would be interesting to consider, do PNH cells have any ability to evade MHC class I predominant marrow failure as we see in aplastic anemia? And so I invite you to stop at the two posters. So I will present here some of our unpublished data. These are just work in progress, and we have some posters that we are presenting today. But I will show here some of the work by postdoctoral fellow Dr. Balorma Munkbileg from my lab, where she also did some of the studies looking at the ability of PNH cells to activate CD4 and CD8 lymphocytes. First, I will show that she was able to reproduce essentially what was published by Murakami, showing again, as you can see here, this is effector cytokine secretion. And we can see in blue that the PNH cells loaded externally with peptides stimulate CD4 cells significant to a lower degree. Curiously, when these cells were provided with protein, so protein is something that you would imagine would be externally endocytosed and then would be processed and then loaded on the MHC class II and then used to stimulate lymphocytes, this defect disappeared. We also did not see any defect in stimulating CD8 positive lymphocytes. However, what was interesting is that an MHC class I predominant model, murine model of immune-mediated marrow failure, where you can see in the leftmost graph in red, you can see the recipient cells. So these would be the hematopoietic cells in the mouse after it's infused with T lymphocytes. They're decreasing. At that same time, with the persistence of this immune attack, we see the rise in the red line of the PNH cells. So there is something there. And of course, in vivo, in the mouse, it's a much more complicated system. And so there are many more things that are left for us to explore. Finally, I will mention one additional mechanism that potentially could be at play. So it has been observed by multiple groups that in patients with aplastic anemia, we frequently see mutations in PGA. We also see mutations in PNH, in HLA, just never in the same cell. So we had a hypothesis that perhaps in PNH cells, we also have a defect in MHC class I antigen presentation, and therefore it doesn't make sense for the cell to lose both genes at the same time. So the work that is presented by Dr. Sushant Kumar in the poster session, he has examined the MHC class I immunopeptidome in PNH cells, observing that indeed there are some differences in how these antigens are processed. And so potentially you could envision a model where an aplastic anemia antigen or a variety of other antigens may be processed differently, leading to its lower abundance, and therefore potentially another means of immune evasion. So, take-home points. What I think I have shown you from the last now 30 years of work in the field is that PNH cells have altered susceptibility to different types of immune attack. Now, the immune association, the close and unique association between PNH and aplastic anemia suggests that probably the autoimmune milieu and whatever forces and effector cells are at play in aplastic anemia, those would be most relevant for PNH clonal expansion. And perhaps now that we have a better understanding of what causes aplastic anemia, we will have future additional insights into the mechanism of PNH clonal expansion. Thank you very much.
Thank you. This is a great honor. I don't know whether we can have my talk. Hey. Yeah, so I'm honored to be able to speak here. I was assigned to this session, and I have to confess that at the beginning I was a little bit upset because I thought that disease. While we have probably the biggest program at the Cleveland Clinic for PNH by volume, this is, only 20% of my labs that deals with this disease, but I am honored nevertheless, and I had to think about one of the stories that David mentioned, namely the boy in the bubble, and like DeVito, who was a father of American chemotherapy, put him in this bubble and nurture him. And one of the things that if you read the book was that the boy was very discontent because he was feeling that his father did not think that he has a manly disease, because his father was a true cancer doctor. And boy in the bubble had only aplastic anemia, only. And when I was thinking, I was assigned PNH, which is lesser of the bone marrow failure syndrome in comparison to MDS and aplastic anemia. I was a little bit tipped off, but I think it's all good because I had to think about this story. And rather than show primary data that we will present at ASH and or rehearse papers that we have published, I thought that it would be a good occasion to summarize a little bit where we are going and where we were and what are the most important questions. So what are the triggers of PNH versus aplastic anemia, and are these different triggers? What is the natural immune privilege? Is this mechanism of immune escape? We invoke this immune escape for many, many years in many review articles. Bruno Rotoli and Lusato and as well as Neil. But yeah, we don't know what the nature of this immune privilege is. What are the pathogenic differences and similarities of primary versus secondary PNH, secondary being the one that evolves after aplastic anemia, and patients who present without any history of aplastic anemia, no matter how intensely you interrogate their past medical history. And why in certain patients the clones keep on evolving and other patients, they just persist at the same level. How about spontaneous remission? The most favorite question of patients who you meet in the aplastic anemia organized meetings. And is the cure without transplant possible? So, I want to answer a couple of these questions, where I think we should be going. But as a general principle, I think it's worthwhile to see the general principle of acquisition of clonal mutation as a somatic gene rescue, which has been used mostly in the context of germline. And my favorite gene, DDX41, this is also the canonical kinase mutation that follows the loss of function mutation, is a form of somatic gene rescue. And here I think aplastic anemia and bone marrow failure is an example par excellence of somatic gene rescue, including the fact that impaired stem cell compartment is less competitive, and it's easier for a clone that has only a certain fitness margin over the normal stem cells to evolve, or there is a certain extraneous circumstance such as immune attack that PNH clone evolves. So if you wish, PNH is a maladaptive immune rescue or maladaptive gene rescue, somatic gene rescue of a failed bone marrow. And, unfortunately, this one light color does not show up on the screen. I see on the big screen, you can see it. But essentially this in chips that, that was so eloquently described by, in this beautiful paper in Blood by colleagues from Harvard, there is a connotation that many of the chip mutations are very weak drivers, and they can only thrive and produce expansion only in the context of contracted bone marrow. And of course, then the disease evolves when there is a second hit. And we still are looking for the second hit in PNH, but in MDS, clearly it is the case that the at least low driving clone that evolves in the context of contracted bone marrow compartment. The best example is, of course, aging bone marrow or bone marrow damaged by chemotherapy. These clones particularly, right? And David describes the cytopenia associated with this as a sickos, but as a general term of clonal hematopoiesis being a form of somatic gene rescue to a pre-damaged bone marrow. So this is general principle that also operates in bone marrow failure in PNH. The other important issue that I mentioned in these questions, rhetorical questions, is of course the primary hemolytic PNH, why some patients evolve immediately and don't have his antecedents history of aplastic anemia versus the other clearly have history of aplastic anemia, but at the end of the day, once they have hemolytic PNH, they are almost indistinguishable. And so is the privilege incomplete? Or are they different? Are there different intrinsic or extrinsic issues that come and drive immediate evolution of PNH clone versus PNH clones that evolve in a setting of aplastic anemia? We and others studied this phenomenon. This is from old paper from JCI that we have published many years ago, showing, of course, additional mutations are also present in PNH. And this was also an attempt to explain why some people evolve faster and some people don't evolve. And one of the good explanation would be that those who evolve faster carry additional mutations. And here you have a comparison between aplastic anemia and PNH and MDS. The number of mutations is much smaller. The clones are smaller in size, but we can find them in a good 40% of patients with PNH. The clonal hematopoiesis outside of PGA mutation. And this once more to demonstrate that the behavior of the clones is erratic, and many of the attempts that we have published showed rather mundane effects in terms of predicting who are the patients in whom PNH clones will evolve. Something like people who have a bigger clone to begin with, they are more likely to have even bigger clones. I mean, it's not very satisfactory. Or patients who got more intense immunosuppression were less likely evolve, so this was intuitive, but I mean, there was really not a smoking gun on clinical grounds to predict the evolution. And as you can see that, now having genetic means and not only flow cytometry, you find that approximately by sequencing with a cutoff value of 1%, we find a good proportion of patients who have PGA mutations, but we find patients who have 2 or 3 or 4 mutations, so the total clonal burden is actually additive, and it explains also why some patients have type 2 and type 3 mutation at the same time. But moreover, we have identified and published a lot of patients who have deletion X or microdeletion of PGA gene on deletion X, similar to HLA. By the way, this is one of the analogies. And also now mutation in PIG-K and PIG-O and so on are increasingly identified. So, these, of course, differences, they might explain some of the differences in the clinical behavior of patients who evolve. This is just recapitulation of evolution. I skip this, and so what are the modes of evolution? And I think studies the natural history on the single cell level will allow you to distinguish different types and systematically studied. We have patients who have just PNH clone, but in a large proportion of patients we find additional clones, and these additional clones can be either constitute a subclonal micromosaicism within a PGA clone. I find it less common, versus this is a competing clone. And the final scenario that is also less likely, but we observe it using single-cell genomics, is the presence of PGA as a hit, secondary hit to a primary hit in the bone marrow that was sort of low driving another mutation. So these are once more schematically exemplified, these potential outcomes. I think that the number 3 and number 1 are the most common scenarios for clonal hemopoiesis in the context of PNH, which of course is not satisfactory because one would like to find the second scenario, whereas the nature of the secondary hit, in addition to PIG-A, determines the expansion, but I think this is not going to explain it. Now, this is a constant question, the dream of remission, and Carmelo Gurnali published this paper of the three patients that were very intricately studied, but we have now probably 7 patients like this, in whom the clonal architecture reveals certain clues, certain nature, lessons of nature in terms of the remission. So we found these patients who were receiving C5 inhibitors and a typical PNH for years, and eventually the PNH sort of disappeared, and the deep sequencing showed this disappearance of the PIG-A clone by being replaced by this plastic clone. In other words, there was another competitor. This was not a subclonal mosaicism, but mosaicism in the bone marrow, and this secondary clone became so powerful that it sort of squeezed out, if you wish, the PNH clone. So the seemingly positive event of losing PNH clone was unfortunately spoiled by the recognition that in some of these patients, the disappearance of PNH clone, a sort of burnout, is associated with evolution of MDS clone. Now, what would be the strategies to cure PNH? I'm going through the list of these questions that I asked rhetorically at the beginning. So, of course, we have this model of somatic gene rescue, whereas PNH evolves in the context of autoimmune attack. And I think the most appealing, theoretically, would be elimination of PNH clone. But, of course, we all are aware that in that case, we would revert the patient to aplastic anemia. So this, while sort of logically appealing, is not going to be possible. And I think the most appealing way to cure PNH would be to improve fitness of hematopoietic stem cell compartment, in other words, discovery of a proverbial booster that would have many, many other applications, including CHIP, CICUS, and other diseases. So this is something, and several were proposed, androgens, nicotinamide, or the so-called Elysium out of Harvard. I hope half of you are eating it, not to age, because it's a stem cell booster, and they are other like EPAC, for instance, or TET2 or DNMT3A inhibitors, which sort of phenocopy CHIP fitness, but by pharmacologic means on normal stem cells. So finally, one of the way to prevent evolution of PNH would be to phenocopy the defect pharmacologically. In fact, there are many drugs that inhibit many of the enzymatic steps of the GPI anchor. And if you imagine if we would administer it together with immunosuppression, then PNH clone would not have a gross advantage. So you would create equality. So the genetic advantage would be equalized by pharmacologic advantage, only temporary. And then, of course, once the immunosuppression is applied, the advantage disappears, and then one could withdraw. So the idea would be to generate, to phenocopy pharmacologically PNH phenotype at the beginning of the immune attack and prevent clonal advantage of PNH cells. And I'm finishing here, and this is a beautiful poster. I had only a couple of minutes of Daria there, and this is the topic of what triggers PNH has been mind-boggling, and of course we all believe that what triggers PNH is what triggers aplastic anemia. But many times I ask myself whether PNH is actually what triggers aplastic anemia. And now how it would be possible, and this is the upper. We know that what makes PNH evolve is gross advantage in the context of autoimmune attack. I think this is a current thinking of the field. But, you know, what if PNH cell or PNH antigen is a trigger of aplastic anemia? If it would be a PNH antigen, it would, of course, explain why negative cells are being selected for, right? Because they don't express the antigen. But wait a minute, we have to slow down. If this is a cellular T-cell response, the protein is still being made, a pro-protein. It's just not GPI anchored, so it would be still presented. So this somehow doesn't jive. The other theory is more compelling, in my opinion, is that PNH cell, by having a different presentation, and here where we agree with Daria, different peptidome, would be abnormal, aberrantly abnormal, and therefore would be able to trigger an immune response that is not specific. How it would be. Like, for instance, if a pre-GPI-linked protein without loss of C-terminus with this omega site, which constitutes the cut where the GPI anchor is attached, this C-terminus, of course, has ability to produce peptides that normally would be underrepresented or absent in PNH in normal cells, versus that would be present in PNH cells. This would trigger aberrant expression of, or aberrant peptide presentation, autoimmunity, and therefore which is not completely selective, because the pre-protein, also the expression of pre-protein being immediately processed to pro-protein, the GPI proteins, is also present in normal cells. So one could, but PNH cells have the privilege. So not only that they trigger it, they themselves can evade it, right? This would be the paradigm. And one of the candidates is, of course, the omega side, because this would be the peptide that cannot be produced once the splicing of the protein happens and C-terminus is removed and GPI anchored attached to the GPI anchored proteins. And this is, this is exemplified here. So PNH can be a trigger, and GPI-linked protein is a trigger. And, you know, PNH as a trigger would have either higher expression of HLA. This has been shown. Previously, somebody from my lab got the IPIC prize for showing this data, but by itself, the peptides that are derived from GPI-linked proteins could be themselves different and therefore constitute recognition points for autoimmune attack in aplastic anemia. With this, I'm going to finish, and I hope we have a lot of stimulating things to discuss, and thank you very much for the invitation. I am not going to go unless somebody asks a question, and the only person who is able to ask questions this pervasive is Steve Gore of me. I'm not going to go to Cleveland and inject barbiturates like the other guys that, like David mentioned, but there was a famous person in PNH history in Cleveland, and this was Thomas Ham, who discovered the Ham test and was professor at Case Western University. Thank you very much.
Thank you, Jarek. So I'm going to switch gears, and we're going to move on to the clinical treatment of PNH, which has clearly evolved and become very exciting over the past few years now. Disclosures. David gave a very nice history of PNH. I didn't realize he was going to do that, but I have done the same here. He talked about Goll and Strubing, who described it over almost 150 years ago, and then Thomas Ham, who showed that PNH erythrocytes showed greatest sensitivity to complement-mediated lysis. We learned subsequently to that many of the hematopoietic cells were missing proteins on their surface, and in 1983, it was described that PNH erythrocytes were lacking complement regulatory proteins on their surface, namely CD55 and CD59. It didn't take long thereafter to realize that all these deficient proteins were GPI-anchored proteins, and then the group out of Japan, led by Taro Kinoshito, first described the mutation in the PIGA gene in 1993. And this led to a whole new idea that perhaps we could impact PNH by targeting complement and inhibiting complement. And a group out of Yale, who was a cardiology group actually, were working on inhibiting complement as a way of limiting heart damage, and they chose C5 as a target because they thought that would be the place that would be the least immunosuppressive or lead to less infections. And so they came up with an antibody. And it was Peter Hillman who heard about this that brought it to clinical trials. He came to the ASH meeting in 2003 and blew us all away when he talked about the 11 patients that he had treated with this antibody called eculizumab, and all 11 who were heavily transfusion dependent quickly stopped their hemolysis. And that, of course, led then to the clinical trials shown there, Triumph and Shepherd, that led eventually to the approval of eculizumab as a treatment for PNH. Now, eculizumab does have one little knock on it, that you have to watch out for meningococcal infections, and everybody has to be vaccinated against meningococcus, and we now have both the type B and the ACWS vaccines that have to be given. Eculizumab was clearly a huge step forward. It significantly reduced hemolysis, and these patients felt markedly better because of that. You see here an 86% reduction in hemolysis in those trials. What we didn't know about at the time, because we really didn't know how thrombosis occurs, was the reduction in thrombotic events. And you see here a reported 92% reduction in thrombotic events. The need for transfusions went down significantly, and all the quality of life measures that we studied in these two studies showed a marked improvement in fatigue. Patients reported it as, quote, life-changing, especially those that had had it for many, many years. This drug does not treat PNH-associated bone marrow failure, so if you have some evidence of bone marrow failure, it's unlikely that you're going to see your white cells or platelets respond. And it did not completely restore the hemoglobin levels to normal levels. In fact, most patients would average around 9 or 10, although they felt markedly better without the hemolysis going on. I just show here the quality of life studies that were done with this, and again, you see improvements in almost everything that was looked at, in particular fatigue. And the thrombotic events, as I mentioned, we did not expect this, but when we started looking at it, yes, thrombosis went down, suggesting there is something about complement activation, whether it's hemolysis or something else with complement, that led to less thrombotic events. Now, being that at least in the Western world, thrombosis was the leading cause of death in patients with PNH, it made sense then to look at survival and what's happened with this. And you see here on the left there, the old survival curve that Hillman published in the New England Journal with average survivals of around 15 years. And then as time has gone on, eculizumab and looking at age-matched controls on the right there, showing that we have nearly completely gotten this back to a normal age-matched controlled survival. And I cannot think of many drugs that have done this in the field, maybe except for the TKIs and CML. But here's a drug that not only makes people feel better, relieves their symptoms, but we're restoring their survival and they're living longer again. Ravulizumab came along as a modification to eculizumab, so it had a longer half-life, which patients really loved. Eculizumab is initially given every week for 4 weeks as a loading dose, and then every 2 weeks. Ravulizumab was given as a 2-week apart loading dose, and then you went to every 8 weeks in the maintenance dose. And you could adjust that if you saw some breakthrough hemolysis that was timed due to pharmacokinetics. There were 2 studies done on ravulizumab. They were both non-inferiority studies. The 301 was in complement treatment naive patients. The 302 was in patients who had been on eculizumab previously. And both studies showed that ravulizumab was non-inferior to eculizumab across all endpoints. So while we can't say this drug was superior, many of us have hinted that, hey, it does give you higher levels and seems to have less breakthrough hemolysis with it. It certainly had immediate, complete, and sustained C5 inhibition over the 8-week periods, and you still need to vaccinate against meningococcus. Now, no drug is perfect, and of course we started to see what we term suboptimal responders to eculizumab, and we've estimated those to be 5 to 20% of PNH. or they still have continued hemolysis and or transfusion needs. And there are several potential etiologies to this that can include the bone marrow failure that goes with PNH. It can include dosing issues, as I mentioned, with pharmacokinetic failures. At least in the Asian population, there is a C5 polymorphism that seems to lead to poor binding of eculizumab. We have not seen that much in the Western world, if at all. And then there's this issue of C3 coating of red cells that I'm sure Antonio is going to bring up in the next talk. There are several additional agents targeting C5 that are in development. Crovalimab, pozelimab, and zilucoplan are all in clinical trials. It's getting harder to pronounce all these. Crovalimab is a anti-C5 antibody that binds a totally different epitope. They use the SMART technology to design this. It is recycled within the circulation, so it has a much longer half-life, which enables it to be given sub-Q every 4 weeks. And there are 3 phase 3 trials ongoing with this, Commodore 1, 2, and 3. The results of Commodore 2 were presented at ASH 2 years ago. It met their primary co-endpoints. There is this concern of this antibody-target-antibody complexes during the time of transition. That is, you have the eculizumab or ravulizumab binding to one epitope, and you get this drug coming and binding to another epitope, and you end up with these large complexes that lead to problems. Again, just showing you the phase 1-2 trial here, and then the phase 3 trial down below, the Commodore 3, where you get the sustained drop in your LDH. Pozelimab is, again, another anti-C5 antibody. It has been FDA approved for this Chapel disease that I've never heard of before, but it has been FDA approved for that. That's an enteropathy. And they're now combining it with a C5 antisense inhibitory RNA molecule, so it hits the liver production of C5. So you get this dual block C5 and also decrease the production of C5. Now, how that's going to play out in terms of are we going to get better responses to this, I don't know. We'll have to wait and see. And finally, zilucoplan is a peptide inhibitor of complement component 5. It's got a dual mode of action that it competitively binds, inhibits C5 binding to C3b, and then also blocks the cleavage of C5 to the C5 convertase. Where these drugs are going to play in the armamentarium, I think we have to wait and see, but they are clearly in development, and we'll just give it time to see where they think they're going to fit. So C5 inhibition has been very successful. It may not be perfect, but it has certainly been very, very good for these patients with PNH. And options for C5 inhibition may increase in the future. Joachim threw his granddaughter up, so I had to throw mine up really quickly just to match that, because if I went home without showing mine and somebody else did, I wouldn't be able to go home. So with that, I will turn it over now to see if Antonio's on virtually, and we can get him on to talk about the proximal inhibitors. Antonio, welcome.
Can you hear me?
We can.
Wow. Thank you, Carlos. Thank you to the Aplastic Anemia Foundation for inviting me. It's a privilege being here for your anniversary, actually, and not here in Bethesda. Unfortunately, I really miss all of you. Unfortunately, there was a conflict with the national meeting. I'm just back from Rome, so well, I will do my best, even virtually. So Carlos already alluded to the fact that extravascular hemolysis is a very important issue in PNH. And back to 2005, actually, I was discussing with my mentor, Bruno Rotoli, looking at the first patient receiving eculizumab, why some of them were getting almost normal hemoglobin, whereas some other ones were still requiring transfusions. And so we demonstrate that C3 deposition was a common finding in all PNH patients on anti-C5 treatment, because basically you block C5 convertases, but you cannot do anything upstream, and the C3 convertase remains very active because of the lack of CD55. This eventually lead to C3 progressive C3 deposition on PNH erythrocytes. And since we have C3 receptors on the liver and on the spleen macrophages, eventually this red blood cells are going to succumb, not due to intravascular hemolysis, but due to extravascular hemolysis. And we spent the last 15 years just working, trying to change a concept that C5 could be the best target for PNH treatment. Eventually looking for other targets, which can include C3, factor D, so all proteins involved in the alternative pathway, using different kind of molecules like engineered proteins, small inhibitors, as well as monoclonal antibodies. And today, I'm very happy to share with you a quite short summary of the data, available data from mostly phase 3 trials with the drugs which are already in the clinic, approved for PNH treatment, or could be very close to approval in the next few months. And we start with the C3 inhibitor pegcetacoplan. Let me start with some in vitro data showing that compstatin is a small amino acid, amino acid is more 12 amino acids, basically close to cyclosporine, which can bind to C3 in any conformation, eventually preventing C3 activation. We were able to show in vitro that this compound is able to prevent the hemolysis, and it also prevents C3 deposition, which basically may anticipate a good clinical effect in preventing extravascular hemolysis. This study was investigated in a phase 2 trial, but I'm showing here the Pegasus data. Basically, this is a phase 3 trial comparing a patient with persistent anemia, despite of eculizumab treatment, randomized to receive either pegcetacoplan or eculizumab. Patients were receiving the two treatment in combination in the very beginning due to PK reasons, so just a run-up treatment here to get the pharmacokinetic level of pegcetacoplan. And the primary endpoint of the study was the hemoglobin level. You can see here that all patients were increasing hemoglobin while they were receiving the two drugs at the same time. Then you see that patient randomized to pegcetacoplan keep hemoglobin level around 12, whereas patients going back to eculizumab in monotreatment basically go back to their baseline values. And you can see here that even when patients in the standard arm were eventually switched to pegcetacoplan treatment, were eventually increased hemoglobin at the level of 11 to 12. So this was the primary endpoint. This has huge effect on transfusion. You can see that 80% of patients were achieving transfusion avoidance, and this was irrespective of the stratification by pre-treatment transfusion needs. Of course, this has a huge impact on quality of life. As you can see here, but fatigue score, you can see in orange the level, the improvement seen with pegcetacoplan that was eventually observed also in patients that from eculizumab switched to pegcetacoplan. More or less same pattern on retics. You see that the reticulocytosis that we see in most patients with PNH, even on eculizumab, basically was decreasing, and patient had a reticulocyte count in the normal range. And if you look for LDH, this is quite interesting. In monotherapy, pegcetacoplan was able to result in LDH levels that were similar, if not better, of those observed with eculizumab. You can see these values in blue as compared with the eculizumab patient in gray. Well, despite of this very good control of intravascular hemolysis, some patients had to discontinue the treatment because of treatment emerging adverse events, and some of them were this discontinuation because of breakthrough hemolysis. So this was a concern. Maybe this is associated with some problem with the PK, so we may still do something for this patient. Nevertheless, of course, this is a concern now when we deal with the use of proximal inhibitors in monotherapy. Let's move to a different part of the cascade, more upstream here at the level of factor D. And we have different factor D inhibitors. I'm going to start with the danicopan, which is a molecule developed by Alexion. You can see here, first of all, that a different anti-factor D agent was able, as the C3 inhibitor pegcetacoplan, was able to prevent hemolysis in vitro as well as T3 deposition. So once again, the same molecule may prevent both intravascular hemolysis and extravascular hemolysis. These were the two initial phase 2 studies that were published a couple of years ago. But here we have some phase 3 data that were presented at EHA last June. Here the treatment, because of the PK of this molecule, was an add-on treatment. So basically patients were randomized, again, patients with residual anemia on eculizumab were randomized to receive either eculizumab immunotherapy or eculizumab plus danicopan. Of course, hemoglobin was the primary endpoint. You can see that the baseline characteristics were very severe in a way, because the mean hemoglobin level for this patient cohort was about 7.5. And you see here that patients receiving danicopan in combination with eculizumab were able to improve hemoglobin values by about 3 grams of hemoglobin, which of course should be quite significantly in the clinic. About 60% of patients were achieving at least 2 gram hemoglobin increase. About 80% of patients were achieving transfusion avoidance, and this was significantly different from the placebo eculizumab arm. And of course, as in the previous study, that was converting a huge benefit in terms of quality of life, as you can see here, by looking at the FACIT score. Once again, there was some improvement in retics that were decreasing by about 80,000 per milliliter. Safety was not an issue here, and the most important, we could not see too many infectious complications, which is always a concern if you try to block the complement upstream. This was given in combination with eculizumab. There is another factor D inhibitor, which is developed by the same company, and I'm going to share with you the data of the vemircopan study. These were presented at the ASH meeting about 1 year ago, and this is the cohort 1 that was including patients who were naive to any anti-complement treatment. You can see that now this treatment is given in monotherapy. I forgot to tell you that danicopan is given orally, 3 times per day. This is given twice per day. And you see that patients with vemircopan immunotherapy were increasing by almost 4 grams their mean hemoglobin. This was once again associated with a huge benefit in terms of quality of life. Looking at the FACIT score, the retics were going down as for all the other proximal inhibitors, because we are better in preventing any kind of hemolysis. And this was also associated in monotherapy with LDH levels that are pretty close to the normal level. So this is very important, because that means that this drug in monotherapy seems able to prevent completely intravascular hemolysis and extravascular hemolysis. And while we are waiting for data from the other 2 cohorts of the study, and hopefully from phase 3 data. Once again, the treatment was very safe, and no patient discontinued the treatment because of the treatment. Last but not least, we were able to investigate factor B inhibitors. Iptacopan is the compound that we were able to test in vitro. Once again, full inhibition of lysis in vitro, as well as full prevention of C3 deposition. Here we have data from 2 phase 2 trials that have been published in the last years, but I'm going to share with you the most recent data from the phase 3 trials. The first one was the APPLY that was presented by Regis Pefau-de-la-Tour at the late-breaking section last year at ASH. Patients with residual anemia with hemoglobin lower than 10 were randomized 8-5 to receive either iptacopan twice a day orally or anti-C5. And you can see here the two primary endpoints. So basically, 51 out of 60 patients were receiving at least 2 gram increase in hemoglobin as compared with 0 in the standard arm. And if you look for the proportion of patients receiving, achieving hemoglobin higher than 12, they were 42 out of 60 versus 0 out of 55, eventually showing a huge difference between the two treatments. This was associated with this kind of kinetic of hemoglobin change, and you see that patients were achieving hemoglobin level with a mean that was higher than 12. This was, of course, associated with a huge benefit in terms of transfusion avoidance. Only 3 patients required transfusion during the study, so 95% were transfusion free versus only 26% in the anti-C5 treatment. This was associated once again with a huge improvement in quality of life, as seen by FACIT score, reduction of reticulocyte count that you can see in green, and the most important, there was no difference in terms of LDH levels. So this compound in monotherapy orally was able to keep the LDH level in the same range of eculizumab treated patients. During the study, only 2 events of breakthrough hemolysis were achieved. No patient discontinued the treatment. There was just 1 case of a transient ischemic attack that was considered unrelated to iptacopan and possibly also unrelated to the disease because the patient had a cardiac problem at time of this thrombotic complication. And just 1 patient discontinued the treatment because of a pregnancy, so that was not associated with iptacopan, of course. These are the data from the the other phase 3 trial that was enrolling patients who were naive to anti-complement treatment. This is a single-arm study investigating iptacopan at the same dose, 200 milligrams twice a day. And again, you can see that the primary endpoint, which was increase from baseline of at least 2 grams, was achieved in 92% of patients. Whereas the secondary endpoint of hemoglobin higher than 12 was achieved in about 62% of patients. You see here the kinetic that was a little bit, was quite low as compared with the other one, and we may discuss if you wish later on. No patient received any transfusion for this part of the study, so all the 40 patients remain transfusion free. Again, a huge benefit in terms of fatigue score, of reticulocyte count, and the LDH was basically back to the normal level. No breakthrough and no thrombosis in this cohort of 40 patients. That was quite impressive for all of us. And again, the treatment was quite safe, no major problem here. And don't forget that these 2 trials were conducted during the pandemic. So I'm going to finish with this slide here, saying that I think the introduction of proximal inhibitors result in major achievement in PNH treatment because we were able to improve the hematological response. And basically, now we know that most patients may achieve hemoglobin level basically normal. Of course, well, the treatment was safe. All the concerns in terms of infectious risk were ruled out. Of course, we are dealing with a paradox that by increasing the response, we are basically increasing the number of PNH erythrocytes that are susceptible to hemolysis if we lack complement activation, complement inhibition, even for a few hours. So there is some risk of breakthrough hemolysis that could be different from the one that we are used to see with anti-C5 treatment. And so we have to make sure that PK/PD of these compounds is very good just to prevent even transient leakage in complement inhibition. Of course, there is a huge discussion right now dealing with the question comparing monotherapy versus combination treatment with proximal inhibitors and anti-C5 agents. I think I can stop here. Of course, I wish to thank mostly the Aplastic Anemia Foundation for the invitation, and of course the IPIC that I'm privileged to chair in the last few years. Thank you very much.
Sorry, we're running short on time, so let me open up just a few questions, and maybe we'll take a few minutes for questions to the panel. Let me start, I mean, yeah, you were saying you're a little bit down on the idea that we can cure this PNH disease through immunosuppression or some way targeting the T cells, yet we see spontaneous remission, so there has to be something that we've missed that will allow us to eventually help these patients. Do you think that's true?
Well, I think some of
Press the button.
the spontaneous remission, I wanted to illustrate that they are really folks or fake remission, but indeed this is just a replacement of one clone that is less aggressive, if you wish, less maladaptive by a myelodysplastic clone, whether there is a remission through just simply healthy replacement with healthy hemopoiesis. I don't know, I have never observed it. Now, as we know, CHIP or even SICUS can go for years without progression, so this might be a good trade-off, depending whether the driver potential of this replacement clone, of this competing clone is high or low. And this we will need some follow-up. But if one could theoretically list the ways that one would get rid of the PNH clone, if I could guess, it would be the boosting of stem cells. And one of the things is that the PNH clone kept on increasing despite the fact that immunosuppressive therapy was successful, which indicates to me the scenarios that we discussed today morning or earlier on is that there might be a scar that is not correctable with current means, and this scar, if you wish, a deficiency of the remaining stem cell compartment is what allows the PNH clone to evolve, irrespective of how much immunosuppression you get. Because if we believe immune privilege theory, the PNH clone should not anymore expand once the patient is successfully treated, but this is not the case. So my bet would be on a new generation of drugs, which I would, call stem cell boosters, and they would be useful in a myriad of applications, including age-related clonal hemopoiesis, etc., and aplastic anemia, of course, as well. Maybe Antonio will, you pioneered the treatment of complement. What do you think about cure of PNH without causing aplastic anemia? In other words, this drug screens that we performed, and we have a compound that selectively eliminates PNH cells, but obviously the theoretical notion is that if you give it to patients, if one would give it to patients, it would cause severe aplastic anemia because all the stem cells that are left are the one of PNH phenotype. Do you have any other ideas?
No, actually, Jarek, I do agree with you because we have to be very clear. What we are doing by using anti-complement treatment, we are treating some manifestation of the disease, but we are not aiming to cure the disease. If we are dealing with the cure of PNH, of course, we have to deal with the kinetics of the different stem cells. PGA mutated stem cells are the ones who are leading to PNH, but there are many other normal or even abnormal cells that may eventually drive the evolution of all patients with bone marrow failure. So I cannot totally agree with you with this concept of super stem cells, which is nice. I would say that these super stem cells should also carry some let's say, resistance to the immune attack, because at least in the context of bone marrow failures, of immune-mediated bone marrow failures, you have to get a cell which is able to proliferate, but some way able to spare the immune attack, which has been eventually demonstrated by all of us. Maybe when we deal with the paradox that we have PNH cell expansion, despite of successful immunosuppressive treatment, we have to admit that most of those treatments were not really successful, because those were cells that are expanding, but we were unable to restore the normal hematopoiesis, which could be the actual goal of immunosuppressive treatment.
But you can treat rheumatoid arthritis successfully, yet the damage done to the joints cannot be reversed. You know, and proverbially you would have to do some orthopedic surgery in order to restore the function, sort of equivalent to bone marrow transplant.
Well, in most cases, you improve the disease, but I mean, even in the most rheumatological disease, the concept of cure is not what we are used to see in the clinic.
Because the treatment was too late or too short. And this, you know, to Dr. Patel's point today morning, is that she wants to start the treatment early where the damage to stem cell compartment is not profound enough that a CR can be possible.
Of course, but on the other hand, we are quite lucky because before getting, you know, manifestation of disease, we have a huge stem cell reservoir. And maybe this is the reason why, despite of bone marrow failure, we are able to keep most of our patients alive for almost forever.
Why don't we, I know we're running behind, so why don't we go ahead and stop and let the MDS team come up and start their panel. But thank you, all my co-speakers.